you everybody for having us. Good morning. Um, Thank you, Sages. My name is Ben Owen. I'm a second-year medical student at the University of Nebraska Medical Center. I was working with the Center for Advanced Surgical Technology, and as I said, our study was an outcomes comparison of open laparoscopic and robotic Nissen fundoplications. We have no financial disclosures, and we are IRB approved. So I'll start with some limitations to our study. We were dependent on ICD-9 codes. Therefore, errors can occur between 0.04 and 0.08% of the time, and our data can only be as accurate as the staff entering the information. The perioperative time is not available for inquiry within the database that we used, nor is long-term recovery past 30 days. So a little bit of background. Conventional laparoscopic fundoplications have been gold standard for 2 decades. However, they do have their shortcomings. They use inflexible instruments, which limits the surgeon's workspace. There is a lack of tactile and force feedback while simultaneously magnifying tremors. Surgeons are placed into poor ergonomic positions, and finally, they have to work in a 2-dimensional space. Robotics approach creates a potential alternative as they can simulate the movement of a surgeon's wrist, provide a steady camera platform, provide feedback, create an ergonomic operating position, and construct 3-dimensional imaging. The robotic approach tends to have a lower postoperative complication rate compared to conventional laparoscopic fundoplications, and it also has comparable outcomes with laparoscopy in regards to hospital stay and perioperative complication rate, although robotic has a longer total operating time and higher costs. For our methods, we use the University Health System Consortium, which is an alliance of over 300 medical institutions, and we also use the International Classification of Disease Codes to sort through the database. It contains discharge information on inpatient hospital stay, including patient characteristics, length of stay, 30-day readmission rate, overall specific postoperative morbidity, and risk-adjusted in-hospital mortality, and also inpatient care costs. A little bit more about the database. The patients are identified at risk for specific types of complications and are reported as a % of cases with 1 or more complications. There are actually 30 specific different morbidities and mortalities, of which there's a long list. These include things like postoperative pulmonary compromise, septicemia, shock, etc. UHC also has a hospital profiler, which allows for sorting based on hospital characteristics such as size or hospital beds, location based on region throughout the US, and teaching or non-teaching. So our results from October 2008 to June of 2012, we found around 12,000 fundoplication procedures. You can see that there were over 2,100 open, about 9,500 conventional laparoscopic, and about 340 robotic assisted. For our results, you can see that there was no significance in groups for age and gender, although interestingly, we did find a higher amount of African Americans. Also, non-Hispanic patients, those admitted through urgent care, were all more likely to undergo robotic-assisted laparoscopic fundoplication. Laparoscopic, in comparison to open, was associated with Hispanic ethnicity and elective admission. When we compared open and laparoscopic, we found that laparoscopic was easily better in every category, as you can see. That includes mortality, morbidity, length of stay, 30-day readmission, ICU cases, and the cost. It's important to understand that the mortality and morbidity is a composite score, meaning that 1 of 30 would have gone wrong. In comparing laparoscopic and robotic procedures, you can see that the cost was higher, which is what we would expect given the prolonged operating times that we found in previous studies, although the UHC database does not record this data. However, the robotic technique also had a significantly higher increase in 30-day readmission Even so, there was no significance in morbidity, which means that the criteria UHC uses to define morbidity, such as wound dehiscence, surgical site infections, that list of 30 different things, must not have been what was causing these patients to be readmitted at 30 days. It could be something like pain or other factors just not tracked by UHC. Therefore, further research needs to be done to discover what exactly these patients are coming back for. While the cost of the robot was significantly higher than laparoscopic techniques, early technology associated with, associated with the use of the robot may account for this and suggest that we are still early on the learning curve. Surgical technique was also compared across hospital characteristics. We found a higher percentage of open surgery was performed in medium-sized institutions. Teaching institutions tended to utilize a higher proportion of robotics cases, while non-teaching hospitals utilized laparoscopy more often. Geographically, robotic utilization was proportionally higher in the mid-continent region and was less utilized in New England. Midwestern region also had a high percentage of open and laparoscopic. Finally, we didn't find any differences in payer mix category, as you can see. So in conclusion, robot-assisted Nissen fundoplication procedures have similar patient outcomes to conventional laparoscopic Nissen fundoplications, except for a higher cost, a higher readmission rate. While the higher costs are expected given the new technology, increasing readmission rates are not explained and require further study. Thank you everybody for coming this morning, and that is all.
Thank you. Any questions from the audience? I start, how confident are you that the codes that you use to evaluate is actually measuring purely open and laparoscopic and robotic Nissen fundoplication, and it's not paraesophageal hernia? The reason I say that is your ICU admission rate in all these categories seems extremely high. 10% for robotic go to ICU, and 8.4% of your laparoscopic go to ICU. Do you have any explanation for that?
I wish I had a better one, but like I said, we can only use the data that we were given based off of the UHC, and that means that there is a certain error rate with it. I'd like to have a better explanation than that as to why there's a higher rate, but I don't.
Okay. Yes. Questions?
Do you think that perhaps the increased readmission rate after robotic may be due to the lack of haptic feedback when you're suturing that crura, and you may be over-tightening that crura and it's dysphagia that's bringing them in? It would be very interesting to look at that. And unfortunately, the two categories that you pointed out were the differences. That's where the difference is going to be very important with the upcoming reform.
Right, yeah, I agree.
Tony Gonzalez out of Miami, Florida. Great presentation. I would be interested to see what happened with the robotic group as experience developed. We know that robotics is a learned technique, and the technology is relatively new in our field. Was there a progression or a difference, and was it based on experience?
That is one study that we would like to do. However, we didn't have enough robotic procedures at the time. I did find one study that was a fairly small study, but it found that a very highly trained and unique team were dedicated to robotic surgery could actually decrease the costs and the perioperative outcomes. But it was a pretty small study, so I didn't feel like citing it. But yeah, that'll be interesting to see.
Professor Cuscieri?
I believe it was the same. I believe it was told.
I think this is crucial to any hospital, because you've got so many centers, and it's important to establish the type of surgery.
It is, yes. Dmitry?
Dmitry Oleynikov, senior author. What I can tell you is that the UHC codes are pretty good. These are the kind of codes that the hospital will get from you when you do an operation so they can bill for it. So they're very accurate. The codes for a Nissen fundoplication are the same across whether you're doing it for a healthy young individual or you're doing it in an elderly patient after a paraesophageal hernia. We cannot discern here specifically how many patients had paraesophageal hernias, how many patients had regular Nissens, because it's hard for us to find that. You can add paraesophageal codes, but many of them don't get added. So what I can tell you is that the patient populations were the same because we did do univariate analysis. So while I cannot answer your question, I can tell you that the groups were the same. I can also say that that it is important to understand that these kinds of databases cannot tell us was the surgeon experienced or not experienced. While we can compare general comorbidities of population groups, we cannot compare one patient versus another patient because these are all aggregate numbers that are scored by the database. So this is not a sharp instrument. This is a blunt tool. But it does show, I think, what many of us already know and suspect, and that is, in the hands of a well-trained surgeon, robotic surgery is safe, it's effective, but there are increased costs, and I'm not 100% certain about the readmission rate. I think that the theory that maybe there's a little bit more pain with the robot because the incision's a little bit bigger may be true. We need to do some more study on that. And yes, I think it's very important in today's environment to know precisely where the costs are coming from, or we're going to have a difficult time moving forward with the technology.
Thank you very much.
Thank you. We're going to continue with the next presentation.
Just have a quick question. And this is not specific to this talk. I was listening to this, an industry-sponsored talk last evening. And the gentleman who spoke said that a robotic surgeon is not a laparoscopic surgeon. You are an open surgeon doing surgery with the robot. Yet here we are now comparing laparoscopic data to robotic data, which kind of seems to be conflicting. The other thing is that his data presented last evening, of course these are randomized studies, do not show any leak rates. He doesn't even check a bile leak that may be possible from a cystic duct misplaced clip. Here we are showing phenomenal readmission rates. I mean, the data is very conflicting, and as somebody from the trenches who's, looked at robotics, the data is very conflicting, and I'm trying to make up my mind which side of the fence am I on, So I don't know if you could help me out with that.
Maybe at the end of the session we can discuss that further.